Hello, everybody who have joined so far. We'll get started in a few minutes. My name is Peter Chin Hong. In the meantime, we'd love for you to answer these demographic questions that are listed here. That'll help us a lot with planning and to know who you are. So again, welcome to today's webinar. We'll get started in a minute or so. In the meantime, please fill out the demographic questions if you can. So I think we'll get started. Can we have the next slide? Great. So just a few slides before we begin. Again, my name is Peter Chin Hong. I'm a professor of medicine at UCSF. This slide is just showing the financial relationships for the content on the web board, on which this is one of the activities. Next slide. This is showing the financial relationships within the last 2 years for the presenter, Dr. Durand, myself, and the planners and reviewers. Next slide. This slide is just showing the CME and ABIM MOC points, as well as other education credits that would be received as a result of taking part in this activity. Next slide. And this shows some of the support this activity has received. Next slide. So a few housekeeping points. We will be taking questions for the Q&A, but please put those questions in the Q&A box at the bottom of the screen, not in the chat. And when you do write a question, please include your full name and institution. That is going to be really important as we call out those questions. So you can also use the chat for chatting with other attendees, but the Q&A is really the main point for the questions. So without further ado, we will start our activity with here are the demographic questions results. So most are MDs, but we have a smattering of many other health professionals, including pharmacists, PAs, NPs, nursing professionals, health educators, and others. So we're really, really excited to have Dr. Christine Durand here today. She's Associate Professor of Medicine and Oncology at the Johns Hopkins Kimmel Cancer Center. We all know her very well. She's been really involved in clinical and translational research focused on people with HIV, AIDS, and hepatitis C, particularly and relevant to today around solid organ transplant and the potential use of organs from HIV-infected donors for HIV-infected solid organ transplant candidates. I've known Christine for a long time, and I would also say she has a big heart, one of the biggest hearts I know. She also likes Taylor Swift. Next slide. So I'll turn it off to Christine to take us on this journey. Thanks so much, Christine.
Thank you, Peter. I really appreciate the kind introduction, and I'm very excited to be with you all today. I think the timing is an exciting time in transplantation for people with HIV, so it's a great time for an update. So let's get started. So the learning objectives for this is at the end of this presentation. I hope that you all will be able to list the eligibility criteria for solid organ transplant for people with HIV, and then importantly, be able to describe the optimal antiretroviral therapy for people in that context. I'm also going to end with sharing with you some new practices regarding organ donation from people with HIV to recipients with HIV. So let's get started with a pre-test question. So if you can answer this, we're looking for in a patient with HIV planning to undergo solid organ transplant, which of the following antiretroviral regimens should be changed prior to transplant? So if you can put your choice there, this is something we'll cover during the learning activity. All right. So for our next pretest question, which of the following transplant practices for people with HIV is limited to research protocols only as of now? You can put your choice there. And again, this is something we'll cover in the upcoming talk. Great. So let's jump in. As many of you are aware, people with HIV are at risk for chronic kidney disease. And this can be due to HIV itself, which can cause nephropathy, as well as some of the antiretrovirals that we use, particularly some of the older ones. But more and more commonly, it's due to metabolic issues such as hypertension, diabetes, cardiovascular disease. So in some, there are some older studies on the prevalence of end-stage renal disease in people with HIV. And both in the US and Europe, it's estimated that about 1% of all people on renal replacement therapy are living with HIV. Similarly, we know that people with HIV are at risk for liver disease. Historically, there's been a large issue with co-infections with hepatitis viruses. And even now, where we have excellent therapies for that, we're still seeing other etiologies of liver disease like alcoholic liver disease and increasingly more metabolic associated steatotic liver disease, also called NASH or NAFLD. And actually, if you look at this study that was recently done in AJT, you can see the etiology of liver transplant or liver failure in people with HIV over time. And if you look to the far right, which is sort of the most recent year of that study, 2018, you can see that the dark black proportion, which was alcoholic or metabolic associated liver disease, has now increased to the point that it is more common than hepatitis C and hepatitis B as causes of liver failure. Across the US and Europe, about 1% of all liver transplants done are in people with HIV, which is now just about over 100 transplants per year. So for these diseases, we now know that transplantation is an excellent choice of therapy for people with HIV, and a lot of this is due to the landmark NIH-funded transplant recipient study, also known as the HIV-TR study. So this study was done between 2003 and 2013 at 21 US transplant centers. You can see the centers listed here on this slide, as well as the PIs for this study. So the outcomes of the kidney study are shown here. This enrolled 150 people with HIV who needed kidney transplants. You can see they had well-controlled HIV with CD4 counts over 200 and undetectable viral loads. And it was a fairly young cohort with a median age of 46, primarily Black men. Up on the top panel, you can see patient survival was excellent, 1-year survival 95% and 3-year 91%. And the bottom panel shows you the graft survival or the survival of the kidney, also excellent. The study population is shown in the black line, and actually every recipient in the United States in the registry is shown in the red line. And you can see that really there was no significant difference between outcomes in people with HIV and those without. On the liver side, the study was primarily individuals co-infected with hepatitis C. So the comparison group was hepatitis C mono-infected individuals. The population was a little bit different as far as eligibility. They did allow individuals with a lower CD4 count, since liver disease itself can cause sequestration of white cells and kind of artificially lower your CD4 count. And because antiretroviral therapy can be challenging to tolerate in people with end-stage liver disease, any HIV viral load was allowed. Population was, again, a fairly young population, primarily white in this case. Now, in contrast to the kidney study, this did show inferior outcomes in those who had HIV and Hep C monoinfection, but a sub-analysis of the group showed that it definitely had a survival benefit for those individuals compared to staying on the wait list. So although outcomes were not optimal, it was certainly the best option at the time for people with HIV, Hep C, and end-stage liver disease. And now, in the current era, of course, we have curative hepatitis C therapies, and this has really been a game changer in liver transplantation broadly, and in particular for people with HIV. So this is a study coming out of UCSF, where they did long-term outcomes in their HIV population, and they do quite a large number there. And you can see, if you look at the figure on the right, you can see the differences in outcomes or patient survival by era. And the era of DAAs, or the post-2014 era, is that aqua blue line that really completely overlaps with the population that does not have HIV. So I would say in today's era, we really expect and have seen equivalent outcomes in people with HIV compared to those without. So what about other types of organ failure? We know that people with HIV are at an increased risk for heart failure, and this can be due to HIV causing a direct cardiomyopathy itself, but then also there are indirect causes that people with HIV are at higher risk for, such as the effects of long-term inflammation, some of our medication toxicities, and of course, metabolic complications as people with HIV live longer. HIV, as I mentioned, can cause a specific dilated cardiomyopathy itself, and it can also cause pulmonary arterial hypertension, but other causes like ischemic cardiomyopathy are becoming increasingly more prevalent in this population as well. And a recent meta-analysis estimated that there's about 1 per 100 person year heart failure incidence in this population, and an overall prevalence of about 6.5%. So how do people with HIV do with heart transplants? We have now data on more than 150 people with HIV from our US transplant registry data. And you can see in the panel on your left, the number of heart transplants per year in people with HIV, which have increased from just a handful in 2005 to now we do on average about 30 or so heart transplants per year in this population. And then the panel on the right shows you survival compared to people without HIV. And as you can appreciate, the curves are really overlapping and not statistically different. People with HIV are also at increased risk for lung disease. This again can be due to a direct impact of HIV on the alveoli and the airways. Also, indirect sequelae of perhaps prior infections like pneumocystis jirovecii pneumonia. And we do know that people with HIV have a higher prevalence of COPD than the general population of up to 20%. And there are other specific lung diseases that are more rare but seen in this population. A recent large systemic review showed that people with HIV did have worse obstructive lung disease, including impaired gas exchange and functional decline more rapidly over time. Fortunately, we also have data to support lung transplantation in people with HIV who develop end-stage disease and need it. This, again, is a slightly smaller cohort even than our heart transplant patients, but in some, there have been about 90 people with HIV who've undergone this procedure in our transplant registry. And on average, we're seeing about 10 to 20 per year now. If you look at the survival curve on the right, you can again appreciate that the outcomes are no different in people with HIV compared to people without HIV. So all of this is really just to support the key take-home message, which is that transplantation is recommended as standard of care for people with HIV who develop end-stage organ disease. It should not be considered a contraindication. And I'm also happy to say we finally have an NIH-HHS guideline in this area. This is a new guideline that was just published in September of last year, and kind of highlights the key recommendations if you have a patient who has end-stage organ disease that you're considering for transplant. I'll say the first bullet, which is one of the most important, is that there really should be equitable access for this population. So on a practical standpoint, I just wanted to talk about what you might do if you are caring for a patient with HIV who you believe would be eligible for or would benefit from transplant. And we'll just go over these 4 steps and hit the key points. So starting with reviewing eligibility, evaluating their antiretroviral therapy, reviewing vaccination status and what opportunistic infection preventative measures they might need, and then finally cancer screening. So let's start with the eligibility criteria. It's fairly simple. Really, the number one thing is that they're on antiretroviral therapy and they have viral suppression. And I'll say here that blips are not an exclusion. So I consider a blip anywhere between 20 and 200. And so low-level detectable viral loads should not be considered a contraindication. Then, of course, they need to meet their standard transplant criteria at the local center, and your center will take care of that. You as an HIV or infectious disease provider can leave that to the team. They will do a very thorough transplant evaluation. If they have a prior opportunistic infection, that is not an exclusion. And in these new guidelines that were just published in September 2024, we did not list a specific CD4 threshold. So in the past, due to the NIH transplant recipient study, oftentimes 200 was used as a threshold, but there really isn't data to suggest that those with viral load with CD4s just under 200 don't do as well. So we have removed any kind of CD4 threshold. The next step is evaluating antiretroviral therapy pre-transplant. We all know there are now many different classes of drugs for HIV. And so you really want to be thoughtful because some of your post-transplant immunosuppression might interact with your HIV medications. The reason for this is that one of the key immunosuppressants that is used after transplant, the calcineurin inhibitors like tacrolimus and cyclosporin, are metabolized by the liver enzyme CYP3A4, and a couple of our HIV medications really impact that liver enzyme. So first are CYP3A4 inhibitors like the protease inhibitors and cobicistat. They, when they're co-administered with calcineurin inhibitors, you can really shoot the level of those drugs up. So you end up having to dose them very, very infrequently at low levels. And this disrupts kind of your standard troughs and peaks. And so even though you can co-administer these drugs, overall your exposure to the calcineurin inhibitors will be lower when you co-administer them. On the flip side, if your patient is on a potent CYP3A4 inducer, which would be the first generation NNRTIs like efavirenz or nevirapine or atravirine, then you will have very high metabolism of your calcineurin inhibitors, and you'd have to give your patients very high doses to maintain therapeutic levels. This can be done, but it is expensive to give those high doses of the calcineurin inhibitors. So for example, in resource-limited countries like South Africa, it's very challenging to give co-administer those drugs. Another caveat is if you are co-administering them and someone stops the NNRTI, you can very quickly have toxicity due to those high doses of calcineurin inhibitors. So to see maybe some of the practical impacts of those drug interactions, if we go back to the NIH transplant recipient study, one thing that was notable was that the population had high rates of allograft rejection. This is the 1 and 3 year rates of rejection at 31 and 38%. And this was actually 3 to 4-fold higher than recipients without HIV in the registry. And so it was really hypothesized that the reason for that high rejection rate might be these drug-drug interactions. And if you look at the table here showing the ART regimens of people in that study, you can see that more than half of them were on one of those problematic drug interaction regimens. So if we go back to the guidelines, what they say about antiretroviral therapy in people on transplant, if you focus in on this red box here, is that the unboosted second generation integrase transfer-based inhibitor regimens are really the recommendation. The good thing is that this is also the first line recommendation for people with HIV generally. So many of your patients may already be on this type of regimen. But if they're not, then you should make every effort, if possible, to change their regimen. Now, if you can't, if you have a patient that really requires a protease inhibitor because of resistance patterns, this would not be a contraindication to transplant. It's just something that you would need to manage carefully post-transplant along with that post-transplant team. The other ART recommendation is that TAF is preferred over tenofovir diproxil fumarate, particularly in kidney transplant candidates because of lower renal toxicity. So what about injectables? Many of our patients now are on cabotegravir rilpivirine. This regimen is not anticipated to have any impact on CYP3A4. So what the guidelines say is there's limited data, but there is really no reason that this should not be compatible with transplantation. So if you have a patient who's stably on this regimen, we would recommend keeping them on that. Logistically, you might need to think about whether or not you're going to have access to the drug but depending on the timing of their dose while they're inpatient, since some inpatient formularies do not carry this. Lenacapavir is actually a moderate CYP3A4 inhibitor, so you can have it work with transplant, but again, you're going to have to really rely on your therapeutic drug monitoring and look at those levels of your calcineurin inhibitors and adjust accordingly. So again, if your patient needs that drug, it's not a contraindication. All right, so now moving on to the next step in your pre-transplant evaluation is really to just think carefully about what opportunistic infection prophylaxis will be needed. Fortunately, a lot of this aligns with what transplant recipients without HIV are going to be on anyway. So for example, for PJP prophylaxis, really all transplant recipients are at risk for this, so they'll be on prophylaxis for 1 year post-transplant. Toxoplasmosis, again, if your CD4 count is below 100, then this is recommended, usually is covered by your PJP prophylaxis as well. So as far as the source for these recommendations, I'm showing you here solid organ transplant guidelines from the American Society of Transplantation, and these were published in 2019. And at the time, we recommended MAC prophylaxis if CD4 count was below 50. CMV prophylaxis is again standard at transplant centers, and they will do this depending on the donor and the recipient's serologies. These 2019 guidelines also recommended doing histoplasmosis, coccidiomycosis prophylaxis, and also considering even lifelong prophylaxis for prior opportunistic infections. But as I mentioned, these guidelines were from 2019, so there are a few things that are going to be addressed in updated guidelines, which are in development right now, to better reflect real world practice. So first, since we've now shifted to not using MAC prophylaxis generally in people with HIV, regardless of their CD4 count, we're taking that out for our transplant recipients as well. I think this will make things easier since that can be a difficult drug to tolerate. Also, for some of the very conservative recommendations around histoplasmosis and coccidiomycosis, many of us don't necessarily use these prophylaxis regimens, so we've kind of relaxed those to say consider, and you really need to make an individual risk-benefit analysis there. And then finally, we're not recommending lifelong prophylaxis for things like PJP. Rather, while their CD4 count is in a range where you think that they might be at risk, you can consider those additional prophylaxes. This can be relevant if you're at a center that uses anti-thymocyte globulin as induction immunosuppression after transplantation, because this will actually drop your patient's CD4 counts quite profoundly. But you can reassure your patients that those CD4 counts will recover over time. So then we've gone through the first 3 steps, and then the final step is to review malignancy screening. This will be done generally by the transplant team as they're evaluating someone. So they'll be making sure they're up to date on breast cancer screening, colon cancer screening. But what I like to say to the HIV providers is that to think carefully about HPV-related malignancies, because transplant itself is a risk factor for HPV-related malignancies. So, for my patients, it is a time where I will recommend a high-resolution anoscopy prior to transplant or within the first year after transplant, perhaps rather than just anal pap smear. All right, so for the second half of the talk, I'm going to switch gears and talk about some of the exciting new developments in the last decade in this area. I believe many of you are likely aware of the HIV Organ Policy Equity Act, or the HOPE Act, which was signed by President Obama back in 2013 and then finally implemented in 2015. And what this congressional act did was allowed for transplantation from donors with HIV to recipients with HIV under research protocols to begin with. So just for ease of language, I'm going to refer to that as HIV D+R+ transplant. And the reason it began as under research only was that there were potential risks that were hypothesized. One potential concern was that you might get a second strain of HIV from your donor, and that might be challenging to manage if the donor had drug-resistant virus. There were also concerns about HIV-associated organ disease in the allograft that might not be picked up based on typical donor evaluation processes. So, for example, we know people with HIV are at increased risk for chronic kidney disease. How would the kidneys from the donors or those allografts function over time? Also concerns about whether this issue of rejection would be amplified with HIV D+R+, and whether or not there might be any increased infectious risk. So over the past decade, we now have more than 35 transplant centers that have really forged ahead with this emerging practice. You can see the different centers that are highlighted on this map. And I'm just going to hit some of the key discoveries that this group that we have called Hope in Action have kind of made over the years of doing these HOPE research studies. So one very interesting and somewhat unexpected finding that we realized right away once these studies rolled out was that we were getting offers from donors that clearly just had false positive HIV tests. This is really a phenomenon of the way we screen donors in the US. We actually use 2 HIV tests on every single donor. And we also use the older antibody tests, which in combination with NAT tests or antigen antibody tests. And these are great tests. They have fairly low false positive rates, 0.1 to 0.5%, as I'm showing you here. But when you test tens of thousands of donors, you will have some false positives. Prior to the HOPE Act, these cases were, for the most part, just shut down, either because they didn't even realize it was a false positive test, or because of constraints in terms of having enough time to do confirmatory testing before the organs were accepted. But once we had the HOPE Act studies open, we could easily utilize these organs in our candidates with HIV who had consented to be followed in a research study. And in fact, it made for a very natural control group as we compared outcomes. So what about the donors that we are seeing donate organs in the era of the HOPE Act? This was a study of our first 4 years and included 92 HOPE Act donors. About 2/3 of them truly were confirmed to have HIV, and about 1/3 were false positive donors. And in some, they donated 177 organs, kidneys and livers only in these early studies. What was interesting about the donors with HIV is that 29% of them were only discovered to have HIV upon their death and their evaluation as a donor. Somewhat of a sobering testament to how far we still have to go in terms of getting people diagnosed and aware of their diagnosis. Of those who were known to have HIV, the vast majority of donors were actually on antiretroviral therapy, and most of them had suppressed viral loads. So when we compared the true positive donors with that control group of donors with false positive tests, we see that generally they're quite similar in terms of their clinical characteristics. So as far as age, sex, race, comorbidities, cause of death, really no differences between the donors with and without HIV that we noticed. What we did see was that donors with HIV were more likely to have some co-infections, for example, prior exposure to hepatitis B, CMV, and syphilis came up as exposures. We were, of course, very interested in this issue of drug resistance. As I mentioned, there were some concerns that you might have superinfection with a drug-resistant strain. And what we found was that people, donors with HIV did commonly have drug resistance, but these were the same types of drug resistance that you'd see even in a new infection in the United States. So I've listed the types of mutations there that we most commonly saw, and these are not, these are mutations that are easily manageable and really don't inactivate most of our first line regimens. Specifically in terms of those integrase strand transferase inhibitors, which are the recommended regimen for transplant recipients with HIV, incredibly rare for donors to carry resistance to that, so less than 5% of the donors. This was all really reassuring, I think, as far as the quality of donors and some of the concerns that I mentioned. So what about outcomes in our recipients? We first did a pilot study at 14 different centers, and this included 25 of the recipients who had donors with HIV compared to 50 controls. We saw no deaths at all in that cohort, excellent graft survival, no difference between the two groups, and no differences in infection rates, serious adverse events, HIV breakthrough, or cancer. This study was not powered for non-inferiority, so we were fortunate to get funding from the NIH to do a much larger study. This was done between 2018 and 2024 at 26 centers and included 198 kidney transplant recipients, 99 in the group that had HIV positive donors and 99 in the group with donors without HIV. Similar to the NIH transplant recipient study from the 2 decades before, most of the recipients were male and Black, and excellent HIV control in the transplant recipients, median CD4 count of 500 and a suppressed viral load. In contrast to that earlier NIH-TR study, more than 95% of the cohort was on INSTI-based ART. So we had a primary non-inferiority outcome, which was a composite of 6 different serious events. So this was a safety composite. And you can see the events listed there on the slide: death, graft failure, HIV antiretroviral failure, SAEs or opportunistic infections. And the curve on the right shows you those who received donors with HIV in orange and donors without HIV in blue, and they are completely overlapping. The hazard ratio between the two groups was 1, so no difference whatsoever. Below the curve, you can see plots of the subsets of those different events. So for example, if you look at the risk of death, the hazard ratio, again, was no different, and all of the different analyses had a confidence interval that crossed over 1. So really reassuring data. This shows you some of the secondary outcomes in a more clinically intuitive format. So I'm listing here the outcomes in the HIV D+R+ group, and you can see the curves in the different figures to compare it to the other groups. But 1 and 3 year survival were excellent. Those who did die, actually, the COVID was the most common cause of death as this study overlapped the pandemic. Graft survival was excellent, and even rejection, which was a major complication in the earlier NIH-TR study, was at a much lower level, and again, no different between our two groups in this study. We were, as I mentioned, interested in the risk of infection, and you can see here there were no differences in infection between the two groups, or no differences in opportunistic infections, which were really quite rare, and no difference in infections requiring hospitalization. One thing that was interesting was that in those who received donors with HIV, there was a higher risk of HIV breakthrough. So what is HIV breakthrough? Essentially having 2 consecutive viral loads over 200, or one that was greater than 1,000. And we did have 13 of these events in our D+R+ arm and 4 in our other arm. So that was interesting, but all of these individuals fortunately resuppressed when they were put back on their ART. And when we looked at the reasons for the breakthrough, it was overwhelmingly due to an interruption in antiretroviral therapy, either due to non-adherence or interruption in coverage. So in a handful of patients, we also did sequence analysis to see if we could detect recipient or donor virus. And when we were able to amplify virus, it was always recipient virus. So it did not represent a breakthrough from superinfection. In addition to these excellent clinical outcomes, we looked at how did HOPE Act impact access to kidney transplant, and found very encouraging results. So to do this, we looked at 324 kidney transplants with HIV that were listed for HOPE kidneys, and we compared them to other people waiting for kidneys at their same center. Over 4.5 years, we found that 70% of those in the HOPE group had received a kidney transplant, compared to only 40% in the non-HOPE group. And also a lower percentage, 22 in the HOPE group, compared to 38% in the non-HOPE group, died or were removed while waiting. This really led to a shorter wait time, just 10.3 months for those in HOPE versus nearly 5 years in the non-HOPE group, and overall 3.3-fold higher transplant rate. So let's shift gears, talk about the liver studies. Again, we did a pilot study first at 9 centers, which included 24 HIV D+R+ liver transplants. And similarly to the kidney, we didn't see differences in graft survival, rejection, serious adverse events, or HIV breakthrough. When we looked at the crude number of deaths, there were no differences, but when we did a weighted analysis, we actually saw slightly lower 1 year survival in the D+ group, 83% versus 100%. This 83%, however, is much better than the historical cohorts. You might not remember the number, but in that NIH-TR study, the 1 year survival was 76%. So still overall reassuring. We wanted to look deeper to see what might be driving this slight increase in mortality. There were more opportunistic infections in our D+ group, but these were primarily CMV viremia, which is one of the most common infections post-transplant and fairly straightforward to manage. We also did see more cancers in the D+ group, which was interesting. And if you look at the table, which shows you the type of cancers, you'll notice that several of them are viral-related cancers, such as hepatocellular carcinoma, anal cancer, which is caused by HPV, and interestingly, a handful of Kaposi sarcoma or HHV-8-related cancers. So certainly something we want to understand more about. Like the kidney trial, we have been funded by the NIH to do a larger liver trial. That study has been completed. I don't have the analysis for you right now, but we plan to present those results in 2026 at our American Transplant Congress. And I can say that over the years of the study, with multiple rigorous DSMB reviews, there were no major safety concerns that led to any recommendations about pausing the trial or changing the consent. So we'll have more data on that to come. Like kidney transplant, HOPE has certainly improved access for those with HIV who are in need of a liver transplant. Here we compared 99 candidates in our HOPE studies versus comparators at their same centers and followed them until they received a transplant, died, or were removed for the wait list. And at 2 years, you can see our HOPE population in the blue line. 91% of them had received a transplant versus only 59% that were not in HOPE. This really shortened the wait time. Time to liver transplant was 2.3 months in HOPE versus over a year for those non-HOPE, and a lower proportion died or were removed from the wait list with a more than threefold higher liver transplant rate. All right, so what about living kidney and living kidney donation? In 2023, we published the results of the first 3 living donors with HIV, and they are pictured here on this slide. The first donation was back in 2019, and then the other donors were over the next year. 2 of these donors were actually non-directed donors, which means they just donated altruistically to someone that they didn't know on the wait list. They all had pre-donation biopsies that showed no evidence of kidney disease and did well post-donation nephrectomy. There were a few very minor but manageable adverse events that are listed there. And if you look at their post-donation glomerular filtration rate or kidney function, it was really as expected for any donor, and that is without up to 4 years of follow-up. I did want to highlight a lesson that I learned that I think is particularly important if you have patients with HIV who might be interested in being donors. And what I will say is not to screen those donors out or exclude them from being evaluated based on their laboratory serum creatinine, because as we know, integrase strand transferase inhibitors can actually impact your creatinine excretion without actually impacting your kidney function. So you can have an artificially higher serum creatinine compared to what your true kidney function is. And if we look at our 3 donors, 2 of them who were on integrase-based inhibitor regimens, donor 2 and donor 3, when you estimated their GFR with serum creatinine, it was much lower than their actual measured GFR, which is going to be part of any standard donor evaluation. So what I would say is, as potential gatekeepers, don't use this as a reason not to let an interested patient move forward with being evaluated as a donor. The other thing that I wanted to highlight about this study was that the 3 donors were actually co-authors on the study. You can see I've highlighted their names there. And not only, were they sort of motivated to do this to help a person with HIV, but for several of them, it was also very meaningful to be able to reduce some of that stigma that's associated with HIV through a very bold act like donating a kidney to help save a life. So this is the data on where we are with HOPE up through the end of 2024. And I can say now that we're in 2025, we've surpassed that 500 transplant mark with now, close to 300 donors with HIV who have donated life-saving organs. If you look at the types of organs donated, one thing that will stand out is these are mostly liver and liver kidney donors. So what about thoracic? Where are we in terms of heart and lung? In 2023, we had our first case report of a HIV D+R+ heart kidney transplant, and the outcomes from that transplant were excellent. And I can say the recipient now in 2025 is still doing fantastic. But this has been, one of a very few transplants. A more recent study on 4 was just published last month, but certainly not reaching the level of the kidney and liver. So why have there been so few? Part of the HOPE Act was not only to restrict these transplants to research, but also to actually impose specific research criteria that all the studies had to adhere to. And I think this was likely unintentional, but one of the research requirements was that a transplant center had to have a minimum number of organ transplants of the specific organ type in people with HIV leading up to their HOPE Act studies. So a minimum of 5 of those transplants over the last 4 years. I already showed you the data showing that heart and lung are fairly rare in this population. So when we did an analysis of transplant programs, who would actually be eligible to do HOPE heart and lung, you can see there in the bolded red box that while a substantial portion of kidney and liver programs would be eligible, it was really only one heart transplant program in the country that could do these transplants, and that is the one program that did that case report that I mentioned. So there was really a push to consider removing this research requirement to allow more programs to participate rather than to have this kind of arbitrary numeric threshold put on these transplants. In addition, I think even programs that were eligible were not fully participating, and the reasons for that are not entirely clear, but doing a research protocol requires a certain level of administrative effort and can be challenging, perhaps for centers who don't have a very strong research infrastructure. So when we looked at the programs that were actually offering HOPE, you can see it's really a minority of the programs across the country, and also really geographically limited, particularly to the coasts. So what the HOPE Act did mandate was that the research restriction and the research guidance would be reviewed once there was available data. And I'm happy to say that an advisory committee to HHS unanimously voted to remove the restriction for kidney and liver transplant. And so that was finally done in November of 2024. And then in December of 2024, they updated research requirements for heart and lung. So although they still need to be done under research to begin with to generate the safety data, they did relax the criteria. So they removed that transplant center experience requirement. They removed the minimum recipient CD4 count and a few other requirements that were really barriers, such as having a separate independent advocate, and also for living donors and deceased donors requiring a biopsy before donation, which is not standard of care for people without HIV. Those regulations were removed at the federal level at the end of 2024. And then after that, they were finally put into policy by the Organ Procurement and Transplantation Network, which really oversees all the activities of transplantation. So as of June 2025, programs that are not participating in research can do kidney and liver transplants from donors with HIV for recipients with HIV. As far as cardiothoracic transplantation, as I mentioned, this is still restricted to research, but we are hoping to generate the data necessary to move this forward into clinical practice as well. There is a pilot study going on at many different centers across the US, and I've listed those centers here on this slide. And as a consortium, we put in a grant to the NIH to fund a rigorous multi-center study, which scored very well, and we're anticipating getting funding and starting that in March of next year. So more to come on that front, and we're very excited about the progress that's being made. All right, so in conclusion, I just want to leave you with a few key take-home messages. The first is that solid organ transplantation is really standard of care for people with HIV and end-stage organ disease. There are now new NIH guidelines that are easily accessible at hhs.gov. pre-transplant, the keys are really to evaluate the person's antiretroviral therapy regimen to avoid these CYP3A4 inhibitors and inducers. As far as the new field of HIV to HIV transplantation, we now have robust data saying that kidney is non-inferior. And we also have good data that it improves access to transplant. I think the early outcomes are encouraging for liver, and more data is anticipated. Living kidney donation for people with HIV is considered safe, and removing these research mandates and relaxing the criteria, I hope will expand access to this practice. So that's what I have for you. And now we can move on to the post-test questions and see if we've achieved some of our learning objectives. You can see the first question there. Which of the following antiretroviral regimens should be changed prior to transplant? All right, fantastic. Let's go forward to the explanation. Let's see. You 100% of you got this right. And I have to say that most of you got it right, even in the pre-test, but we did bump it up from 93% to 100%. So that's the correct answer. You want to change the regimen that contained cobicistat because that will cause drug-drug interactions with your post-transplant medications. And now for post-transplant question 2, which of the following transplant practices is limited to research protocols only currently? All right, so go on to the explanation for that. The correct answer is A. 78% of you got that, which is definitely an improvement from the pre-test. So now we have removed restrictions on all the other types of transplants. So a living and deceased kidney and liver transplants may all be done outside of research. The other organ types like heart transplants remain restricted to research until there's sufficient data supporting safety. So I think there's a small proportion of people that thought living kidney would be restricted to research. And I probably covered that point very quickly, but I'm glad that we have the post-test explanation or post-test question to kind of remind everyone that if your patients with HIV are interested in being donors, they don't need to do it under research protocol. They can be referred to the transplant center for evaluation, just like anyone without HIV. So I'm going to stop my share now and move on to the Q&A.
Great. Thanks so much for seeing. You were so efficient in your presentation and yet move the dial in the pre-test, post-test questions. So congrats for being a great teacher. So we'll go through some of the questions that was submitted as well as the questions that came up live. And this is a reminder for those, please submit questions in the Q&A box at the bottom of your screen if you'd like. The first question is really about eligibility criterion. So first of all, OIs. What about PML? That often comes up in the early days. I think PML was something that people were nervous about. How do you think about PML as an exclusion criterion for recipients? And this comes from Raul Rodriguez from Medical College of Wisconsin.
Yeah, that's a good question. So just to review, the NIH transplant recipient study had inclusion-exclusion criteria, and one of the exclusion criteria was certain opportunistic infections. So that kind of became baked into our clinical care. And so PML, for example, was one of these exclusion criteria. Now, when you're faced with a patient who's got a remote history of PML and is in need of a organ, life-saving organ transplant, I would say it's really a risk-benefit analysis, because we know that being on dialysis really increases your risk of a fatal cardiac event. And theoretically, we worry that could PML be reactivated with a transplant? Well, it's possible, but again, that was kind of just a conservative exclusion criteria that was placed in a research protocol. What you do in real life, I think, is you would counsel your patient and you would say, we really don't have data on PML, people who've had PML and had transplants. And so this is kind of unknown territory. How do we as a team make a shared decision about risk benefit? And just I would present it that way. So great question.
Great. Thanks so much, Christine. I would say that's also our experience here at UCSF. The next question comes from Harry Rosado from the University of Utah. And he's again sticking with the recipients. What about patients who are elite controllers with high CD4 counts, not on ART? Should this group be on ART if you're thinking about putting them on transplant, since you're thinking about the donor who might be different from that recipient?
Yeah, this is another fantastic question. So I think that, and I've had patients like this before. And again, I think when you go through transplant, you're going to get very intense immunosuppression, particularly at the time of transplant. And we know that elite suppressors are probably controlling HIV with great T cell responses. And for kidney transplant patients, they'll often get antithymocyte globulin, which really knocks down their T cells. And then they'll be on multiple medications that are suppressing T cell function. So I think different people have different opinions on, again, whether to do kind of shared decision making and monitor people to see what happens. But I have really recommended to my patients that we just put them on ART, given that ART these days can be, as straightforward as, one pill once a day or injections a few times a year, and not kind of put them at risk for having a HIV reactivation or breakthrough while they're immunosuppressed. So, but Peter, I'd sort of be interested in your thoughts on this. I think it's another, there's not clear evidence, so it's kind of a judgment call.
Yeah, I mean, I agree with you. There's a variation in practice. I would say talk to the patient, but I've seen cases where people get put on maybe pre-transplant or peri-transplant, and then they are followed, and then collaboration, it's a team effort. You can see or decide at some point if they're doing well from a transplant perspective, maybe holding back on the ARTs and seeing and following them very closely.
Yeah. If people have patients like that, I'd love to see it in the
Yeah.
literature. So, because that seems like a nice middle of the road approach where you kind of wait till the period of most intense immunosuppression is over, say, after 6 to 12 months, and then do some careful monitoring then.
Yeah, definitely. Sticking with the recipient in the eligibility pathway. This question comes from Kristen Lindauer from Centara Health in Norfolk, Virginia. And she asks, what if a patient has extensive resistance to NSAIDs and the transplant team refuses to transplant a kidney if the patient remains on that? What are the best options to consider? How do you think about working with that phenotype in a potential recipient? I mean, do you think about dolutegravir twice daily with the Scovy, other options? That's the question.
Yeah, so shout out to Centara, who's kind of in the region here near me. So I think, we've, at least in my experience, I've had patients where I've had to really directly advocate to the transplant teams about moving them forward. The way transplant is done is there are these selection committees, and oftentimes people are averse to like risk and sometimes moving forward with new things. So if I had a patient who was suppressed on a regimen that was sort of a contraindicated regimen like a PI, and they needed that because of multi-drug resistant virus. As I mentioned, I would not consider that a contraindication, but just would manage the co-administration post-transplant. If there certainly are centers maybe that wouldn't move forward, and of course, in that case, I would probably advocate for my patient to get evaluated at another center. But even with new drugs, I think ideally you'd be able to find a regimen that can suppress the patient, and even the drug interactions again themselves shouldn't be standing between a patient and a life-saving organ transplant if they need that. So you can certainly manage these these interactions. We did so in earlier eras before we had INSTIs. So if you need to, you can do it post.
Yeah, definitely. I was just thinking that myself in the early days before NCs, a lot of people were on protease inhibitors, and you had to manage these drug interactions. And I think people got into trouble when they were you didn't have high enough levels of the anti-rejection drugs, like the calcineurin inhibitors, because of the drug
Yeah.
interactions.
So you might again just counsel them. You might be at an increased risk of rejection. What they actually do in Europe, which we've never adopted over here, is they aim for tenfold higher peaks of the tacrolimus, because on these regimens, that's what you would have to do to kind of get the right area under the curve or exposure. So you can do it, but I think what we've done here is just sort of maximize the safety profile and accept the higher risk of rejection.
Yeah, like you said, it's always a risk benefit, and the probability that that patient may not do well if the patient didn't get transplant, despite the risks. We have a really couple of interesting questions coming from Brazil. One is from Mayara Seco, who's from Fiocruz in Brazil, and asks for donors with detectable HIV viremia, so switching to the donor side now, would you genotype them and tailor the recipient's ART scheme accordingly? We get that question a lot on the transplant center side. What's the genotype? Do you have the genotype? Can you tinker with the donor? But again, you're kind of always faced with the aspect of time and the available information that you have, which is not often readily available.
Yeah. So with organ offers, as Peter alluded to, you kind of have this very short window of decision making. So the way we try to do it is when we get an offer from a donor with HIV, we ask for any HIV records. And this is kind of a new practice for the organizations that are helping with donor evaluation. So they are learning to kind of do this. And sometimes it requires doing a physician to physician on call, call in the middle of the night to try to get HIV provider information. But oftentimes you're going to have to move forward without that information. You could ask for a genotype, but it takes 7 to 10 days to get that back. So you won't be getting the genotype before you have to decide yes, no. I didn't really have time to cover this, but we've done a lot of studies looking at whether there is superinfection from donor virus, both here in the US and in South Africa, where they really pioneered HIV to HIV transplant. And what we found is we have not seen much superinfection. That is like the donor virus actually infecting the recipient and causing long-term infection. So I think we worry about this less than we did at the beginning of the HOPE Act experience. And so if we can't get the information, we'll often just move ahead because, worst case scenarios, if there was breakthrough viremia post-transplant, you could get a genotype at that point and try to manage it. But really, I haven't seen that in any case in the, like 500 transplants we've done. So I think it's more of a theoretical rather than like a practical concern.
Thanks, Christine. And then a related question from the donor perspective. This question comes from Joseph Yao from the Mayo Clinic. What do you, how do you approach viral loads in donors? You know, what if the donor has a viral load between 200 and 1,000 copies per mil, and you have to make that decision about whether or not to accept that organ? How do you
Yeah.
approach that? You may or may not have info. You may or may not be able to talk to the HIV primary care provider before you have to make that decision about organ allocation.
Right, great question. So again, if we go back to the South Africa experience, which was really the first experience of HIV to HIV kidney transplant, almost all of the donors were not on antiretroviral therapy. So they were accepting kidneys from donors with very high viral loads. Here in the US, there's no restrictions on, donor viral loads. So we accept both types, donors that are untreated and then donors that are on treatment. We won't generally have a viral load at the time of organ acceptance. So we might have a clinic note if someone's in care saying whether or not they had an undetectable viral load. Or we may have a qualitative NAT test, which is what they do to show that they're undetectable. But oftentimes we won't have that data. So again, similar to what I said for the last question, in the beginning of the Hope Act experience, we're a bit anxious about this, but we're carefully moving forward as far as our donor decision making. But now that more data has really accrued, it doesn't seem that the donor's viral load or resistance pattern really poses a significant risk to a recipient who's already on ART. It may be that the ART is almost acting like a post-exposure prophylaxis, if you will. So they're getting exposed to a new donor viral load, but it's not really causing clinical issues, if that makes sense.
That totally makes sense. Thanks so much. Sticking with the donor perspective, one of my own questions is really about OPOs and organ procurement organizations. How have they changed over time? I remember in the beginning, you kind of had to meet with different regions. You kind of, you're working with the transplant centers, but at the same time, there are these OPOs who have to have buy-in as well to even take the opportunity. The question they always ask is the juice worth the squeeze? Working up these HIV potential donors with a whole host of other things they have to do, and having maybe some uncertainty in whether or not they'll be able to allocate those organs. Have things changed? Are they more accepting? Are there regional differences?
Yeah, great question. So for those on the call who don't do transplant all day, all night, organ procurement organizations are contracted by the federal government to do the donor evaluation and donor coordinate all of the donor organ recoveries. There's 56 or so that roughly correspond to each state, though some states have more than one, and they're led generally by a clinician, either nurse or physician, and they have coordinators who go on site and evaluate donors for potential. There is incentive for them to maximize the number of organs per donor. So, particularly in the beginning of Hope, when it was just kidney and liver, there was some hesitation. Also, just a lot of sort of stigma and lack of education kind of in providers who maybe aren't as up to date on HIV care and things like that. So in the beginning, it was a smaller number of OPOs that were really participating, but I would say I think nearly every OPO in the country has now done at least one. We continue to have kind of a 24/7 on-call hotline to support OPOs or organ procurement organizations when they have a donor. And I think, there are benefits to donor families to be able to see that their loved one can, donate an organ. So there are incentives. And so I think it's just, practice. We're human beings, and practice changes in behavior and practice take time. And so we've certainly seen a good amount of progress and participation over time. And I hope we continue to see that, particularly now. I think if more transplant centers are participating outside of research, then that will be even more incentive to the OPO community to kind of have a place to have these organs land.
Great, thank you. Coming to the recipient post-transplant phase now. This question comes from Vitor Classman from Fiocruz in Brazil. Um, Again, can you review the risk for virologic failure after the transplant has occurred? You had mentioned sort of ART interruption in the peri-transplant period. Uh, what are the risks? And because of that, and also another question really that is there a risk of what is the current state of thinking around risk of rejection during the HIV viremia?
Okay, yeah, thank you for that question. So if in our 200-person study, we had a total of 14 people who had an HIV breakthrough or HIV viremia, which, is a fairly low proportion of people. And generally speaking, they were resuppressed within the next check, kind of within 3 months. So nobody had sustained breakthrough or virologic failure, which was reassuring. And we actually didn't see any increased complications during that period. So generally speaking, it was sort of picked up on fairly quickly by transplant centers because these patients are getting labs quite frequently. And then once recognized, seemed to be very well managed. So we haven't had a case that led to issues with graft dysfunction or rejection or anything like that.
And a related question of my own is, what is your thought about, particularly in kidney transplant patients that creatinine that draft hasn't taken yet. There's this period where there's a lot of changes in creatinine clearance. How do you manage the antiretroviral therapy in that peri-transplant period?
Yeah, good question. A lot of our patients will have what we call delayed graft function, where they'll need to remain on dialysis for, say, more than a week after transplant. So I think, you're potentially going to be changing dosages because of renal recovery post-transplant. I'd say most of our current regimens, fortunately, you don't have to worry too much about renal toxicity. So for people who are on our INSTI regimens, you can generally just keep going through, even with the fluctuations in graft function or as the graft recovers. So it's fairly you just have a lot of people kind of watching kidney function and dealing with dose adjustments during that time.
Great, thank you. This question is talking about just vaccination. One specific vaccination, based on what you talked about, is HPV vaccination. This comes from Maria del Castillo Garcia from Kaiser Permanente. She asks, is HPV vaccination recommended pre-transplant, given the concerns for HPV-related malignancy in the transplant population? Many of our transplant recipients may fall outside of that CDC range. They're not teens anymore or young adults. How do you approach that?
Well, I apologize, I didn't have time to go through all the vaccine considerations. There are some nice guidelines about vaccination in your pre-transplant patient, which I generally, there's not a big difference in HIV versus people without HIV, but this is a great question. I'm actually interested in your thoughts on it, Peter, because you have a lot of experience with HPV specifically. If you had a 41-year-old come to clinic who hadn't been vaccinated, what would you do?
I'm glad I'm intrigued by the fact that you turned the question on me, Christine. But yes, I mean, I think if you think about who benefits from the HPV vaccine, it's not really about age. Age is really a public health recommendation. It's really about probability of exposure to the types included in the vaccine. Now we have a non-covalent HPV vaccine. So if somebody, say, had one or two sexual partners lifetime, and they're coming up for transplant, they probably have a very low probably, even if they're in their 40s or 50s, they have a low probability of being pre-exposed to a lot of the types, including the vaccine. So that's kind of the way you approach it. And of course, that's an extreme. But if you think they would benefit from the vaccine, you can certainly, it's very live, not live, it's safe. You can have a discussion with the transplant team and the patient and use it off label, as long as that it can be paid for. So that's kind of the spirit of how we think about it, because again, the risk of HPV reactivation post-transplant is high, and even in an immunosuppressed patient getting exposed to a new HPV type that you can probably avoid by using the vaccine.
Yeah, I agree. If you can get someone to pay for it, I give it.
Yeah,
Unlikely to harm.
yeah, it's definitely. One question I think is really intriguing comes from Martin Gisinger, and he asks, do you believe that a time will come when HIV positive persons will be able to donate to HIV negative recipients?
Yeah, great question. This has already happened in Africa. So there is a case that was published of a mother living with HIV whose infant child needed a liver transplant and they could not find a donor. So the mother became a living liver donor, and gave part of her liver. And that was successful. I personally think we should consider that type of transplantation. We are considering xenotransplantation in this country where we're using pig organs. So why not use an organ from a donor with a very treatable disease? The issue is probably more of a political one. Right now, it's not legal, so we would have to, again, get an act of Congress. And then I think there's probably more of a psychological stigma related issue. But I am optimistic. I hope that we can get to that point in the future.
Great, and we're at time, and we have just a few more slides for the audience for those who can stick around. I think I got carried away by the exciting questions, so thank you, Christine, and Tammy, if you can show the next few slides. So this is information on how to get CME, etc. Next slide. These are some upcoming events. There are many cool ones like on bacteriophages, many offerings from the IAS-USA, including one on medical cannabis with Dr. Abrams and Dr. Sag, and gender-affirming hormone initiation and ART considerations in people with HIV, as well as one on patient adherence and engagement in care, now available on demand. These are some upcoming courses, one in Chicago, star-studded cast, also another one in medical management of people with HIV as they age for non-geriatricians, another virtual course on emerging challenges in HIV medicine. CROI next year is in Denver, Colorado in February, for those of you who would see. And thank you for participating. I thought it was just fantastic. I certainly learned a lot. And Christine, you're a great teacher. And thanks for all the Q&A, extended Q&A session.
Yeah, thank you to the great audience for participation, and thanks, Peter and IAS-USA. It was really fun.
Bye.